Well, good afternoon, everyone. We're very happy to see you here on our SEPA Synod webinar. Our topic is COVID considerations for church leaders. And we have with us Dr. Tim Babinchak. He is a member of St. John's in Phoenixville, and he has been an epidemiologist for his career for 40 years. He is retired fairly recently from being the chief of infectious diseases at Thomas Jefferson University Hospital. And he continues to work with some groups, pharma and medical folks, to help develop therapeutics as well as vaccines. So we are very, very happy to have him with us today. Before we get started, I want to quickly launch a poll to just find out who is here. So this should come up on your screen, and if you would take a moment, just indicate whether you are a rostered minister or a church staff person or a lay person in a decision-making role, or whatever else you might be.
You forgot the category of Reverend Bishop, Bob. I see our bishop is there.
Yes, you're right, I did. Sorry about that, Bishop. So looks like almost everyone has voted. So if you haven't, a last minute there. And let's take a look at, we're almost there, 96%, 98%. Okay. So let's just take a look. You should be able to see the results there. We're 56% clergy, 11% church staff, 30% lay council members, and 4% other. So welcome all of you, whatever role you have. We're going to spend some time today talking about the very strange situation that we're in. We are blessedly in a time that vaccines are going up and cases are going down, even though they're still high in some parts of the country. And we also have new guidance coming out, it seems, weekly from various health leadership organizations. And we know that politically, it looks like the state is going to open up almost completely at the end of this month. So that puts us in a very interesting position as church leaders, making decisions about, do we gather on Zoom? Do we gather outdoors? Do we gather in person in our worship? How many people can we have? What precautions do we have to take? And so that's the context in which I want to turn it over to Dr. Babinchak to help us get started making these decisions.
Thank you. Thank you very much, Pastor Fisher, and thank you to everyone who's joining today. This is, as I've said to Pastor Fisher, this is an extraordinarily difficult and for a lot of people new time. This is a situation where a new disease literally has been introduced into our world, and it is an infectious disease. Some of us are old enough to remember other infectious diseases that were very important in our lives, going back to vaccines for measles, going back to vaccines for polio. And the best analogy that I can make for the coronavirus and COVID is, for those who are old enough to remember, was the introduction of AIDS and HIV into our world. And it is a fact that these things do not discriminate. They do not have any way to be avoided or to necessarily, they don't play favorites here. So, but and importantly, we have both technology and we have opportunity in order to minimize the risks that are there. As Pastor Fisher has said, my background, I have been an infectious diseases specialist for over 40 years. I'm originally from Ohio, so the Midwest, born and raised in Ohio, completed both my medical school and my graduate training at Ohio State University. Spent a large portion of my career, my early career, in Pittsburgh. Came out to the Philadelphia area in 1998, and so I've been here since 1998. A member of St. John's here in Phoenixville as well. And I was about to retire right before COVID hit. And after preparing all my life for these kinds of things, it was not an opportune time. So I have spent the last year helping and treating COVID patients, both personally and in helping others, as Pastor Fisher said. And I have served on a number of different areas and worked for pharmaceutical companies in my later years, Pfizer in particular, Wyeth before that, and some smaller pharmaceutical companies to develop anti-infectives, and most recently to develop both the COVID therapeutics as well as the vaccines. I retired officially from seeing patients in January of this year, 2021, when things became more stable here in North America. I turned it over to the younger folks to handle the day-to-day aspects of it. However, I'm still very actively involved. I sit with a number of groups, not just governmental groups and medical groups, but other industry groups for return to work and for guidance in these things. So I do appreciate your giving me the opportunity to speak with you, first of all, and second of all, and most importantly, to respond to your questions. And as Pastor Fisher said, one of the ground rules that I have is that I'm going to give you and try to give you the best scientific information that I have available from a global basis. And that pulls from the US sources, but also sources from around the world that may have a different perspective. Because as we all know, the sources of information that we receive often have different agendas, and those agendas are often very different than the personal agendas that we all have. And particularly, Dr. Fisher, Pastor Fisher and I have talked about this earlier, the perspective of the church and the worship community is very different than the perspective of the restaurant community. It's very different than the perspective of schools. It is different than the airline industry or manufacturing industries. There are different considerations that need to be taken into account in those. And so my goal today is to try and give you as much information as possible for you to make informed decisions that are relevant to the situations that you have. I cannot give blanket recommendations because the decisions that are that need to be made in each of these circumstances are based on very personal, in a lot of cases, assessment of risk as well as comfort. And the agendas can vary so differently that the ultimate decisions become yours. What I can try and do today is to give you information and give you avenues of information that you can use to make the most informed decision, because as Pastor said, this information changes on a weekly basis and sometimes on a daily basis. At that, I'm going to pause at this juncture for just 1 second to highlight that point for just a moment. In medicine, one of the caveats that I always had with my patients was when someone is ill or when something happens, that the time frame that we put around the healing process is very important. As technology has come through medicine, you see lots of electronics, you see lots of numbers, you see lots of gauges, and I very frequently see patients just become mesmerized by the heart monitor, by the pulse oximeter that's on their finger, by the numbers and the technology. And when that changes very slightly, there is either elation that it's getting better or utter fear and dread that somehow the numbers aren't going in the right direction. And one of the things that I've always tried to do with my patients is to get them to understand that those fluctuations are going to occur. And on a daily basis, there are going to be days that you feel good and there are going to be days that you feel bad. But in the course of your illness, it's important to ask yourself, how do I feel this week compared to how I felt last week? Am I on a better trajectory? Day to day, if we slice things too finely, we find ourselves in very confusing and oftentimes conflicting areas. And so the time frame that you put around things is important to get an understanding, because situations change. These are fluid situations. Importantly, for COVID and coronavirus, I threw out that old paradigm, because once you get into a global situation with a new disease that's introduced, it's no longer how are we doing this week compared to last week. I don't even look how are we doing this month compared to last month. I broke this down for most everyone into 6-month blocks, because it truly is 6 months where we will see changes in science. And so if we think about where are we now, May 11th, compared to 6 months ago, where it was December 11th. And on December 11th, the first vaccines were just being authorized. And the country was waiting to try and get 20 million doses into people by the end of the year. And there was this great anxiety around all of these things. We were planning for the Christmas season. I remember doing this very, very importantly. How are we going to get through Christmas? But now, fast forward 6 months, and we're in a situation where vaccine demand is actually now declining. All of that anxiety has gone away. We have a population that's much more protected in a number of ways. And if we go back the other direction from December 11th to where we were on May 15th in 2020, I was up to my ears in hospital patients, not knowing what were the best therapies to use, drawing on different science from around the world, looking at different drugs. And by December, we had the treatment paradigm down pretty well. We knew which drugs may be helpful. We knew how to use our medicine better. And then we had the prospect of the vaccines coming in. All that to say that when we get to December 11th of this year, we're going to be in yet another different situation. We're going to have more vaccines. We're going to have more knowledge. And that's the key. The knowledge continues to evolve. And I can tell you what the best thoughts are around that knowledge now. And as I said, that's my hope, to give you information that allows you to make informed decisions. So where are we now? Okay. And what can we expect? I think the most important thing, and the most, well, first, my mea culpa, the most frustrating thing for me as a physician has been my colleagues and other physicians failing to acknowledge that this isn't going to go away. Right? And I struggle with that on a number of levels, because I understand the idea of hope and things, but it's important to understand that we are now in a world with COVID. It's not going to go away. We're not going to have 2019, 2018 again. This is an infectious disease that is going to be with us, just like we don't have a world without HIV. HIV is with us. But what we've learned to do is to develop therapies, to develop ways to work and to treat and turn what was an absolutely devastating disease in its earliest forms into a chronic and treatable disease. And that's the trajectory, that's the timeline that we're looking at with coronavirus and COVID. It's not going away. And fortunately, we are working very quickly toward getting ourselves into that particular situation. The most important part of that situation currently is the availability and the activity of the vaccines that we have here in the United States and that have been approved on a global basis. So it truly is a remarkable achievement in going from a new disease entity a little over 18 months ago to vaccines that are both effective and have safety profiles that are, while still being determined, are remarkably good for the vaccines and for the development programs that went along. And I'll do my best to try and answer your questions around these vaccines as much as possible. I'm sure there are. But the important aspect is that the vaccines that are currently available are effective at doing the most important things, which is reducing hospitalizations and reducing deaths. Now, you notice I didn't say eliminating, all right? Nothing is perfect. There are people who are going to be vaccinated who are going to get COVID. There are people who are going to be vaccinated that are going to get COVID and are going to pass. This is not 100%. So there will always be these anecdotes. And that's why I say it becomes a very personal decision, both on a personal level, but also on a congregational level, as to what are the risks that we personally are willing to take, and how are we going to translate that information to the greater public. Because while vaccines are effective, there are large parts of our congregation and of our world where the vaccines aren't going to work. They're not going to work as well. They're not going to work as well in patients who have had organ transplants, or that are currently on cancer chemotherapy, or that are on immune modifying drugs for other diseases. We know that the vaccine effectiveness is not as good in those individuals. And so what then becomes our priorities or our responsibilities in protecting those individuals within our within our congregations, or within our life in general, in those respects. So I've taken a good bit of time here to try and introduce some of those things, but I really want to leave this time for your questions. And I know that you've sent some of them to Pastor Fisher. So that's, I hope, a general background, and I'm sure that through all of the questions that you have, we can hit a number of these other points. I want to really address what is important for you. So.
Okay, thank you, Doctor. And I do see there is a question in the chat from Pastor Serena Sellers. Pastor, are you able to unmute and ask your question?
Sure. So my question is, what is the current thinking about singing outdoors, masked or unmasked? And we're committed to only having worship indoors if the 14-day positivity rate is below 5%. If masks are worn and distance is maintained and 70 to 80% of those present have been vaccinated, is singing still a high risk activity?
That's it, absolutely. This is, as I've said, music and singing is such a fundamental part of our worship services, and always has been. And I know how important that is. I'm going to answer it on two levels, okay? So the first level is I'm going to give you the specific answer, and that is for individuals who have not been vaccinated or could be ill, singing is a high risk activity for those around them. All right. So yes, it is a high risk activity. Point one. Point two, masking those individuals, singing with a mask, helps. So if it's masked and then separated, that's very good. If it's outdoors, the risk is even less. So I hope that answers the specific part, because now I'm going to go to the general part, which covers a lot of the other questions. So it's sort of like your high school journalism class: who, what, where, when, and how. All right, who. So if you've been vaccinated, if your congregations are vaccinated, that's the best thing. It doesn't mean they're not going to get it. It means that they've done everything they can do to reduce those risks and the risks of others around them. All right. So the WHO, vaccinated persons, but as I've already said, it's the unvaccinated that become then the vulnerable population. And everyone asks me, what's the magic number? Because the magic number that is being promoted out there is this 70%. Okay. I have to tell you, all right, that's what in my lifetime we called an MIU, and that is made it up. We don't know what that number really is. All right. It differs. And the reason we don't know that is because it differs by disease. So to eradicate smallpox, we knew that we had to have nearly universal vaccine coverage to do that. But we know that to reduce the threat of pneumonia due to Streptococcus pneumoniae, we only have to have about 60 to 70%. But that's a 30% spread. So right now, everyone says 70%. My learned opinion is we don't know what that number is. And is there a safe number? Probably, but I'm going back to my 6-month time frame, and this is why I introduced this. At 18 months, we don't know that. By December, we may. So here's where the risk calculation starts to come in. You may know how much or have the pulse of your congregation to know how much of your congregation is vaccinated. And that's excellent. The more that are vaccinated, the greater the risk tolerance that you can have in that situation. So that's the who. Where is very important in that outside activities, outside worship, outside singing, outside even without masks is probably doable. It's not probably doable, it is doable, all right? And with appropriate spacing, family clusters can be together, but separation of the family clusters, outdoor transmission is exceedingly rare in controlled situations. All right. And so where is important. Outside, you want to have your Bible schools this summer with the kids outside. Absolutely. All right. Maintaining distance, hand washing. When I say these things, there are a few caveats. One is distance is maintained, you wash your hands, and you're respectful of those around you who you don't know the vaccination status of, because they're the vulnerable ones. And this is especially true of the children, all right? We've just had approval for 12 to 15-year-olds, but consider anyone that hasn't graduated from high school as vulnerable. And not only are they vulnerable, they're actually dangerous because they're the ones that are going to be transmitting the virus. So it's a two-way street in Sunday school. It's a two-way street in Bible school. Not only are the children at risk, but if you have your personnel that are vulnerable, they are at risk as well. So that's the who. The where, outside, inside. Now, inside is important for worship services for a couple of reasons. And that is the inside is dependent upon the circumstances that you have in your church. So the better the ventilation in your church, the greater the risk tolerance that you can have in that situation. All right. You can throw the windows open, throw the windows open. if you're doing the community services, if you're doing Alcoholics Anonymous, you're doing the other counseling activities that are often done in smaller rooms. Again, maintain the distancing. You can do those things because the where is important because of the how long. All right. So your risk is dependent upon who's there, how close they are to you, for how long, and what that activity is. That's the key. So an hour and 15 worship service in a large church setting with groups, family groups separated, masked, singing can occur. All right. We all know what happens at Christmas and Easter. And we all know how but it's important to keep that. So outside, fine. Inside, the more you can do to make it like outside, the better we are. So who, where, what, the when is sort of the how long we're together. The longer the exposure, the greater the risk. And so, do we need to do Zoom meetings? No, we don't need to do Zoom meetings. We don't need to do Zoom worship. However, and this is a consideration, because this is the way medicine has gone, all right? A large number of patients are no longer seen in doctors' offices because they can have the majority of their checkups, they can have the majority of their what used to be in-person visits done remotely. And it is safer for them as well as safer for the rest of the people in the doctor's office. So my recommendation is, and this is the how part of it, is how do we want to continue to deliver God's message in this way for worship services? How do we wish to do that? And if we go back to in-person worship, does that mean we're not going to do these other types of delivery that actually helps certain parts of our congregations? And so I still recommend that when you think about these things, the how, in order to minimize the risk to potentially the most vulnerable, you may want to consider continuing certain aspects of the worship journey that you've done for the last year in order to protect both those who are in church as well as provide opportunities to those who are out. Okay. So I know that was another little long-winded one, but I'm hoping that helped to clarify some of the, can we go back inside? What does it mean when we go back inside? And how far do we have to be? Can we sing? Yes, you can sing. Outside, you can sing. Inside, you can sing. I would continue to wear masks for the singing. My favorite is, well, if we sing quietly, can we do the liturgy in response? Can we do it quietly? And yes, you can do that. Because this is the world, we're entering into a stability period. We're not going to see a lot of change in the next 6 months. The world is going to start to open up, and we're going to see this. All right. And so the last part, your pastor, your parameter around 5% is a very good parameter. All right. That gives an idea of what the level of transmission is in your particular community. And this now becomes what I call the reasonableness doctrine. And that is, because nothing is 100%, because we can't protect everybody, what can we reasonably do that sort of protects as best as we can those who are vulnerable, but also allows for a situation, whatever it is, worship, grocery shopping, whatever it is, allows for a reasonable expectation of the activities of daily living, for no other words. Okay, and that's the reasonableness doctrine. 5%, absolutely, but that goes back to the personal aspects. If I'm an organ transplant person who hasn't responded, my risk is not going to be 5%. My risk may not even be 1%. It's going to be very personal in those regards. And so that's what we need to weigh and to take into consideration. Other questions?
Yeah, thank you, Doctor. I see a couple interesting ones in the chat. One, I think refers to what we were talking about, the guidance from different sources changes at different times. And we've certainly seen some new guidance from the CDC just last week, I believe, which talked about the importance of aerosol transmission and actually suggested that perhaps 6 feet may not be enough distancing, at least in certain circumstances. And along with that, Pastor Warren Wellick did ask a question about some of the state regulations. Pastor, do you want to unmute and share your question?
Thank you, Pastor Fisher. News reports and even the PA website appear to have either contradictory information or there are big holes in it. So my question is, first, the governor is talking about lifting the mask requirement when we hit 70%, they're saying mid-June. For indoor worship in the church, am I hearing you correctly that if we plan to sing, it should be soft singing, as it's been suggested, and that we should require masks to be worn for in the general context of a congregation, even after the governor has lifted the requirement in Pennsylvania?
So, as I said, I'm not going to be able to. So here, my answer is going to be, I feel potentially that my answer is not going to be satisfying. And this is the reason why. And that is that I can't tell you what that is for your individual congregation. What I can tell you is that if your congregation is at risk or vulnerable, the way to minimize that risk in the congregation is to maintain the distance, to sing with a mask. Those are the ways that you reduce the risk. All right, though that makes the risk less. You're doing the things to lessen the risk to those that may be vulnerable in your congregation. And you may not know who those are, because we don't get a scarlet letter to identify who's been vaccinated or not in those situations, nor should we. So the answer is the 70% is an epidemiologist's best estimate around what is likely to decrease the transmission to the point that we are under 5% and that it becomes a reasonable number. All right. As I said, I know for smallpox, it was nearly 100%. For measles, it was nearly 100%. For pneumococcal pneumonia, it's about 60, 70%. So it's a reasonable estimate. Is it magic? I don't know. Here's what I can tell you. All right. And this goes to the reasonableness doctrine. All right. About 60% of us get a flu shot regularly. All right, year to year. That's another transmissible respiratory disease. And COVID is transmitted in the same way as influenza. That's why influenza disappeared. All right, because everything that we did to try and keep COVID at bay made influenza go away. Now, as we take those things away, influenza is going to come back as well. We know that 60% vaccination rate doesn't make influenza not happen. All right. But it was a reasonable risk that we all assumed before. We sang without masks. We did all of those activities before. And so that's where I'm trying to help you set what your reasonable risk tolerance is going to be. So, and there's one other aspect that I just want to make clear, and that is the masks. The masks are not to protect the person wearing the mask. All right. When I go into surgery, I don't put a mask on because I'm afraid of the patient. When I go into surgery, the mask is on me to protect the patient. All right. That's the other key aspect. So wearing the mask is in consideration of others. And that's a very important aspect that we have to look at. So when we put the mask on to sing, or we put the mask on in public places, you know, the mask mandates, the government, all of those kinds of things, that mask, and again, I struggle with this because I think it's poorly communicated. The mask mandates are not to protect the person wearing the masks. The mask mandate, and I don't think it's said often enough, are a gesture for the protection of others. And that's where the key is. And so from a congregational standpoint, as a leader, my words are, look, if you think that you could potentially be putting others at risk, the one thing you can do and still attend our services and other things is put a mask on, because you're then doing everything that you can do to try and minimize the risk that you may pose to others in that regard. So 70%, yes, it's as good a number. I don't have a better number. I'm not saying that it's 80 or 90%, or, you know, we're going to be okay because we're already at 58%. All right. What I can say is that the 58% has made it so that the strain on the infrastructure, our hospitals, our healthcare workers, our society is approaching a reasonable level in that. No death from COVID is an acceptable death. And eventually I want to get there. Just like preventable things should be prevented as much as possible. I hope that's helpful.
Another thing that has come up in a number of conversations is the availability of the so-called singers masks. Is it do you think worthwhile for singers, at least singing leaders, to have some sort of special masks, or the standard masks that we're all wearing sufficient?
So yes, and these this goes to, as I said, our 6-month blocks, where in May of last year, everyone was scrambling to find an N95 mask because somehow that was magic. All right. The advice that I give to people is that, depending upon the circumstances that we're looking at, an N95 or specialized masks are really only necessary in those situations where you're likely to have prolonged or repeated exposure. And so that's why healthcare workers who are dealing with these individuals are really wearing those masks, because they don't have the opportunity to open the window, step outside, limit the time, limit the distance, et cetera. And that's why I took the time to go through the who, what, where, when, why aspects of it. All right. Quite frankly, using a regular blue surgical mask and then using potentially a cloth mask over it will give nearly the same amount of protection. Now, most importantly is not what the mask is made of, but how well the mask is fitted and how well it's worn. All right. And this is for my students and for the residents in the hospital and things. I tell them, if you're comfortable in your mask, it's probably not on correctly. All right. So it's not a chin strap. Okay. It's kind of like your CPAP device. Okay. If you're comfortable in it, it's probably not. But the good part is, again, for singing, it's a limited exposure at a certain distance, and while it is a higher risk activity, it is not at a risk as being in a small room together for a very long time.
Thank you. Thank you, Doctor. And I see in the chat, we have a number of questions, actually. Kathleen Karen has 2 questions that I think are would be of interest to folks. Kathleen, can you unmute yourself and join in?
Yes, thank you, Bob. A couple of questions have been arising in my council meetings and with other church leaders. So for example, having more voices than just mine in worship. It's just me right now. To limit movement in the sanctuary is a big deal, and I made a big deal of it. But how much difference would the risk tolerance be if I had someone walk up to the lectern, read, and walk back? Or does it matter?
So very important. And again, this is stuff that, again, evolved. Last May, you were afraid to touch a box that appeared on your front doorstep lest it transmit the virus to you. All right. And our knowledge has evolved so much more. All right. And it was the cleaning aspects of the church. Do we clean in between the 8 a.m. worship and the 10 a.m. worship, et cetera, all of those things. The virus is, again, very much like the influenza virus. All right. It doesn't last long on surfaces. It doesn't last long outside much at all. So the opening the door handle and all of those kinds of things, if it's an outside surface, the virus loses its activity. It doesn't go away. All right. And this is where it's very important, because this is how the misinformation comes in, because scientists and doctors look for what, can we find it? can you find it at all, or do you find it in amounts that are actually dangerous? Okay, so walking back and forth to the lectern, absolutely fine. I am not afraid of, and you can do it unmasked even, all right? You do not catch this virus walking past someone, all right? We know that any more than you caught influenza walking past someone. So yes, more voices are very appropriate in those situations. Absolutely. You had another question?
Yes, thank you. The next one is questions about temperature checks. People coming in, you know, I'm a teacher, so I as well, and I do that. I mean, is that really going to save us? And I get it about risk tolerance and all that, but I'm just wondering what you think.
So temperature checks were one way that we could try and screen people earlier on. All right. And that was just another layer that was added to try and reduce that risk. They're relatively inaccurate. Okay. They're relatively inaccurate. And the psychological benefit of the temperature check was far greater than the actual benefit of the temperature check in reducing these. So if I'm going to have to pick my battles, the battles that I pick are with hand washing and are with mask wearing and social distancing in those. Those are the more important battles that I'm going to really try and stress more than anything. The others added layers of protection, but just like we talked about with the specialized singing masks, all right, and I call in my reasonableness doctrine here, it becomes a point where the reasonableness just doesn't justify the added cost, the added things that we need to do. To use the vernacular, all right, the juice isn't worth the squeeze in this one.
Thank you so much.
Yeah, there certainly are some things that are perhaps better at making us feel more comfortable than actually doing anything. One question I had gotten by email relates to that. It's actually, I guess, a three-part question. May we open restrooms at church for use by congregants? Do we have to wipe clean pews after use? And is it safe to return hymnals and Bibles to the pews? Those are all things that initially churches were being advised to do. What do you think, Doctor?
Okay, so absolutely, please open your restrooms. All right, that's how you get your hands washed. So absolutely, please open your restrooms. All right, and if you haven't learned it in kindergarten, remember the old book, Everything I Needed to Know I Learned in Kindergarten, and that is the right way to wash your hands, dry your hands, so that you're actually not contaminating any surfaces if you're washing your hands correctly and going to the bathroom. So please, yes, open your restrooms. Second, do we need to wipe down the pews after each service? If you have good cleaning protocols within your church and you're not doing services that are essentially back to back to back, all right? Now here's where I've had this situation with some of our Catholic friends where they just keep us, it's nearly a continuous service within some of their churches. And if that's the case, then that becomes part of the who, what, when, how long, because you're not giving enough time for Mother Nature, the activities, to take care, to reduce that risk enough. So if you've got an 8 o'clock service and then you go to Sunday school, etc., you do your adult education classes, and then you do a 10 o'clock service, do you have to wipe down in between? No. Okay. That's enough time. All right. And it's really only those that are sort of really piggybacking one on top of another. First point. Second point, can you put the hymnals and the Bibles back? Yes, please do. Okay. Yes, please do. And here's the caveat of that. Okay. And this is why I go back to that. And that is your risk is low because your congregation is washing their hands and they're not coming to church sick. All right. The most important thing is if you don't feel well, please don't come to church. Regardless of whether you think you have COVID or any other illness, if you don't feel good, please don't come to indoor worship that way.
Okay, thank you. Thank you. That clears that up. There was, in relating to the distancing, and I mentioned, I believe, that the most recent CDC document indicates that because of aerosols, 6 feet may not be enough. And let's see, Henry had put in, he said, you mentioned made up numbers, and says one source said that 3 feet is fine. What do you think?
Okay, so this actually did have science behind it. All right. And so here's what we've known, and we've known this for influenza, and actually it was originally done for tuberculosis. And so the way that these things spread, when we talk, my talking here creates an aerosol. That aerosol has these little droplets on it, which are the primary means with which these pathogens, whether it's tuberculosis or influenza or COVID, are transmitted. Now, the 6 feet comes from, if I'm talking, the largest of those particles are falling right in front of me. And as you go further and further away, it requires smaller and smaller particles, and the risk gets less and less and less the farther away that you are. So the 3 feet comes from, most of the particles are gone by 3 feet. But to give that added extra protection, we made it 6 feet. It wasn't that one's not a made up number. That's one of the ones that actually has science behind it. And so does the 3 feet. The 3 feet for normal conversation, especially masked conversation. And this is where it came for the schools, and why the schools were going to be allowed to have students at 3 foot intervals, but that's because the students were all going to be masked. Okay, so with a mask on, you're not generating those particles. They're not going as far. Your risk is at 3 feet with a mask is nearly equivalent to an unmasked at 6 feet. Okay, so these are the trade-offs that we look at. That one's not a made up number. All right. I will tell you, as my Canadian colleagues did, and very early on last year, because of hockey being their national sport, their ushers and their church greeters stood at the door with their hockey sticks and said, if I can touch you with my hockey stick, you're too close. And that's how they spaced out their congregations. And they asked all their families to come bring their hockey stick and make sure that they couldn't touch each other with their hockey sticks.
Okay, thank you. I'm also thinking that our congregations since you mentioned schools, have contact with children in a lot of different ways. Children in worship services, children in Sunday school classes, teens and youth group, and some of our churches have preschools. Are there other things that churches should be looking at dealing with taking care of children under their care?
Yeah, so, and this is, again, an extraordinarily important part of all of the worship services and the continuing of education and just childcare that is provided by a number of congregations. And for most of those things, here I'm going to sort of separate things out. When it comes to specific childcare activities, it's very important to follow the guidance for the childcare activity, not for the worship activity. All right. And because they're very different circumstances for the reasons that I talked about, where the children may not be ill, but would still be able to transmit the virus. And in those situations where you don't know what the status is of the caregivers or the adults in that situation, both of those populations become vulnerable. And so it's not appropriate to apply the worship activity risk parameters that you do around the child care activity parameters. And as we move through this, hopefully in another 6 months by December, we'll have vaccine that's approved even for those younger than 12. And so by the fall, we're going to have a much more normal school year. School is going to be able to resume in-person schooling in a lot of activities. So the most important way that I can try and answer that, Pastor Fisher, is to look at it from the standpoint of the child care activities. Now, when we talk about Sunday school, when we talk about summer Bible school, et cetera, things like that, then the worship activities are the same because we're looking at the who, what, where, when, and how activities there. So Sunday school, an hour at most, you can maintain the distancing, you have those activities, which is very different than day-long child care that you're doing for working families, et cetera. And so for the educational activities, whether they be adult or children that our churches and our community do, it is then appropriate around still hand washing, spacing, masks are helping others, etc. But those, again, because it's the limited time that's different than the true day-long childcare activity or the school activity.
Right. Thank you. I see Pastor Sabo has a question in the chat. Do you want to unmute and join us?
Yeah, Bob, I was just wondering if there was any kind of concern for those cleaning our sanctuary and narthex when they're vacuuming, since it's airborne particles.
Yeah, and so the short answer is no. Okay, and this was a very important aspect, and actually where a lot of the information came from, and that is that industry did not see an increase in COVID cases from the custodial activities. All right, as long as they do the same precautions, all right, their risks are no higher, custodial activities are no higher risk than others, because again, they're generally dealing with disinfectant products, first of all, and the sweeping and the other activities. Is it zero risk? No, it's not zero risk. All right, but it is a reason. It is no greater a risk. Let me put it this way: I'd rather sweep your church than be in unmasked choir practice at your church. Okay. we know what the risky activities are at this point. Custodial activities have not been shown to have an increased risk of contracting coronavirus.
Okay, thank you. Another one that came in my email, and this was driven, I know early on there was a lot of concern about people being together and sharing any kind of food, or how, and the question of course came how to do communion, even outdoors. So how would you suggest we think about the possible risks of giving communion?
Absolutely, and this is where my earlier introduction with HIV was important, because we've struggled with this with every infectious disease that comes along. This is one that doesn't have a lot of science behind it, but it has a lot of experience behind it. And this is where vaccine and vaccination really helps. So the best way, and this is the one departure that I'm going to make from the science, from my earlier pronouncement of not putting a stake in the ground. And that is, if you're vaccinated, please enjoy communion as you always have. If you are unvaccinated or feel vulnerable, my recommendation is, as a church, to offer alternatives to the normal communion that you usually have, and have that be just as you would a shut-in or someone else that would otherwise be unable to take community communion in that situation. And so providing an option, I think, is the most reasonable way to provide the Eucharist moving forward.
Okay, thank you. And Pastor Casey offered a question.
Yeah, just wondering if there's any concern regarding the playing of a pipe organ in worship, aside from it might encourage singing.
No, please play the pipe. The organ itself is not in any way making it dangerous. That's again, the more you can do for ventilation, the better. But no, the pipe organ has not been linked to any specific bad activities. Keeping the sick people out, that's the important part.
Yeah.
Great, thanks.
Thank you. And so another in the chat here from Clyde, it says, COVID is aerosol borne. What is the minimum rate of air exchange in order to have minimum risk for indoor worship?
Okay, I'm not an HVAC expert, all right, I will tell you that. But I'm going to answer it generally, and that is the more the better. What the minimum is, again, that's going to depend upon the situations of your particular church. I don't have a particular number that we do that. In the hospitals, I can tell you, all right. So in the hospitals, we have increased the capacity of our HVAC units for air exchanges within the hospitals, but we haven't done anything truly dramatic. And a lot of those things have gone away. The most important thing is we now enter spring and summer, but really the best thing you can do is, where you can, throw open the windows.
It really does keep coming down to these very simple things, doesn't it? There is, and I placed a link in the chat to a document from the World Health Organization, which gives a sort of a flow chart for how to assess your ventilation situation. Place to start, of course, is with your HVAC people, if depending on your system. And of course, opening windows is a good way to start. They do indicate ventilation rate of 10 liters per second per person. I don't know if that's meaningful or not, but
Yeah.
that's what's in their document.
Yeah. And again, the reason that I hedge on this is because these are recommendations that are very different. Okay. So that the ventilation rate that I want on my airplane is very different than the ventilation rate that I need in my church pew or in my hospital or in my manufacturing plant or my preschool. Again, because it's the length of time of that exposure that is also a pertinent factor in there. And that's why no one number it necessarily is a correct or incorrect number in that regard. With limited time activities in the what and the where, that's what I continually have people, when I have these conversations, that's the continual thing that I go through. It's the who, the what, the where, the how long, and that's how I guide the conversation to get people to frame what their risk tolerance is and to frame what their exposure may be in those situations.
Thank you for that very helpful rubric. This might be a time just to take a very simple second 2-question poll to kind of get a sense of what you are doing in worship as of now, or are planning, since we're on the cusp of relaxing restrictions. And so I'm going to pop this up here. There are 2 questions and they're multiple choice. You click everything that that applies. And we'll take a minute or so to do this. And we'll give it just a couple more seconds here. Okay, so here's what you said. 70% of us are worshiping online. 34% are worshiping online and in person. And there's more outdoor worship than indoor worship, which is one of the blessings of spring and summer in Pennsylvania, right? It's good to see that 96% of you are requiring masks in person. 94% are doing social distancing. There's not a lot of singing, and there are some folks who are limiting attendance to make sure that the building's not too crowded. So thank you very much for those. Appreciate it. So a couple questions have popped in here. Let me take a look here. Rich Martz, do you want to ask your question?
I can. I it just fascinates me that opening up a window and blowing air across people makes for better ventilation than using the church's ventilation system. Why is that?
Because you're not in a closed box. All right. And so your airflow is absolutely correct. And so we learned this very early. And this is, I've been a student of medical history for a very long time. And this is the reason that the TB sanitariums in all of our communities are placed at usually the highest point in our county, because the wind blowing across the highest points of our county reduced the transmission of tuberculosis in those situations. When if you really paid attention to certain of the hospitals, when COVID first came, the first thing they did was to move their triage outside, because the more airflow that you have moving through, remember, it's not just that you are exposed to anything that may be floating around, it's the dose that continues to float around in that. So one probably doesn't do it, two probably doesn't do it, but 100 may. In the closed box, you don't have that dilutional effect of the outside air coming in. And so the airlines did this very efficiently. So in an airplane, the amount of outside air that actually comes in is very controllable. And so without having to do absolutely anything else on an airplane, all they did was increase the amount of outside air that actually flows through the cabin, because they can't open the windows in an airplane that way. But it is truly just the dilutional effect of reducing the potential dose that you that you are potentially exposed to, as opposed to being in an enclosed box and relying on your HVAC system to recirculate that.
Okay, thank you. It's very helpful. I know a lot of the churches that have had HVAC inspections, a lot of the interventions they're trying to do is to increase the amount of air flow, outside airflow into the ventilation system, which, we've spent a lot of time trying to make sure our buildings are airtight, so they're for energy efficiency. And now we're looking at how we make them safe with some ventilation. And there are ways to do that. Your HVAC contractors, I think, could give you some good advice on that.
That was kind of my point, because in a lot of these older churches that had all these stained glass windows and whatnot, they've sealed up the outside of the building with storm windows and whatnot, and don't have that many windows that can be opened.
Yeah.
So how can you get that many volumes of air exchanges to make it practical?
Yeah. And that is the difficulty with a lot of the churches. It's inner city churches where the windows have not just been sealed, they've been barred and everything else. It's a very difficult situation.
And that's something to be considering in your context. If you can't provide ventilation, that's a factor in your decisions about whether you go indoors, outdoors, go back at all, or stay on the line. Another question that popped up here asked, are some congregations doing hospitality, coffee and snacks after the services? That's more a question for all of us than for Dr. Babinchak. So if you want to share any thoughts, feel free to unmute and share your experience.
Augustus, no. we've been doing in-person worship for a while, but we'd love to do it, but the answer is no, because we're not sure people are going to social distance and they have to take their masks off to put anything in their mouth. So unless Dr. Babinchak can tell us a way of doing that safely, we're going to keep, I guess, being unsociable.
I don't know that I can tell you how to do it safely. What I can say is outdoor activities are less risky than indoor activities. Okay, so and your opportunities to maintain the social distance from the outdoor standpoint, again, it's not what's safe, what's not safe. It's what's the risk that we're willing to take in order to protect those who are the most vulnerable among us.
We have done ice cream socials outdoors for like a smaller group, our Sunday school teachers and students. But that's as much as we've done. And encouraging everybody to stand far apart and to wear their mask when they're not actually putting food in their mouths.
All very reasonable. All very reasonable.
Grace in Pottstown, typically for Ascension, has root beer floats. We missed it last year, but we're going to do it this year on the 23rd out in the parking lot with hot dogs and doing social distancing, and we'll see what kind of response we have. We've been in-person worshiping since Palm Sunday. So we'll see how the root beer float thing goes.
I'm glad to hear that. I think these are all very good, and you're meeting the reasonableness criteria. Okay, that's clearly we all want to be safe. There comes a point though where we're reaching that point around transmission and stability where we're going to have to be reasonable in the kinds of things that we get back to.
This past Sunday, we had an experiment, and because it was Mother's Day. And we had individual cakes and cookies and donuts and individual drinks and so forth that were available for people to grab and go if they wanted to, or to take and eat. I watched that process, and what I watched was a group of folks who haven't seen each other in a while get closer and closer. And because they were outside, mask wearing, it didn't go by the wayside, but it got infringed upon greatly. And I was like, I had a feeling that was what was going to happen. But they were outside when they were doing it. And I have no control over what folks do out in the parking lot. To a certain extent I can, but only up to a point. And what I did notice is that there was a gender difference. And I don't want to spread rumors, but I was just observing, and there was a gender difference in how people observed and didn't observe. Women were more inclined to wear masks and social distance, while the men were like, I really don't give a care. And I want to talk, and I want to be close to my buddies and so on. So that was an experiment, and I don't know when we will have another one of those, but that's what happened. We had a social function earlier with ice cream out in the parking lot, social distance, and that went better. But that was before we said, well, we'll try this experiment. So I don't know. I think the inclination of people is to want to be closer. We are social beings, and the more opportunity you give for that to happen, it will happen. What I insisted on was no conversation in the narthex, and keep on moving. If you're moving out, move out, but not inside the building. So that was the best I could do.
I think that's very reasonable. Okay, and here the other one of my other credos is we are not social engineers. All right, we can do our very best to just as I am here, try and give people the guidance to make the decisions, but they become their own personal decisions in these situations. And I can provide the information that I can, but people are going to take and do with that information as they please. I try to put it in the context of what our obligations are, not only to ourselves, but what our obligations are to those around us who may be more vulnerable. That's the way that I leave it.
Okay, and I saw in the chat, Karen appeared again, asked about, can we talk again about fans? Do you want to unmute and share a little bit more about what you're thinking there?
Sure. What I was told, and again, this is an earlier time, so I understand that, but the science made sense. So if you put a stationary fan inside the building, inside the sanctuary, it's blowing air, as opposed to fans from the ceiling that push it down. But does blowing air blow the droplets onto others? And is that a good ventilation, or is that still something we should avoid?
Again, not really my area of expertise. I'm going to be very upfront, and I'm going to have to defer that to people who are better ventilation experts than me. I don't have any science, and this is, as I said, I'm trying to give you not my opinion. I'm trying to give you the best science, the best information that I have from around the world, and I just don't have anything to answer
that. Okay, thank you for your honesty about that. There is so much that we're still learning, and we will continue to learn.
Now, the questions are very insightful and very important ones. And as I said, I use the experiences from around the world. And so Pastor and I were talking previously. I have a very good group of individuals and physicians and contacts within Israel. And you can look, Israel can be used as sort of a surrogate for what we can anticipate to happen. And this is where, the numbers games, et cetera. Israel is one of the most heavily vaccinated countries in the world at this point. And while their rates are not zero, their hospitalizations, their deaths, et cetera, are quote manageable and are reasonable. The restrictions that they have are not as severe as the things that we're talking about here today. So their worship services are going on without masks. Their worship services are going on indoors. A lot of this, but it is because of the great amount of individuals that are vaccinated. And there's one other very important difference, and that is in a societal situation, they are a more compliant society from the standpoint of if they're not sick, they're not going to church, they're not going to synagogue. There are social mores that are a little bit different than here, and that's what makes things just a little bit more difficult to extrapolate to. Where I can make those extrapolations, I will. And that's why, for me, it's a very hopeful time. because the more that we can encourage vaccination, the more that we can get our populations to accept these, then quite frankly, the less profound the masks and the social distancing and the other things are going to be. And just as we've moved away from the temperature checks, okay, if we can get to these areas, we can move away from these other aspects as well, except for the hand washing. Please, everyone, wash your hands.
That's one that should stick with us for a long, long time. Another question that popped in is maintaining a high level of humidity still important?
Yeah. Again, these are areas that, again, not my area of expertise. The virus itself is relatively agnostic to the humidity. It transmits just as well in India as it does in Saudi Arabia.
Okay, thank you. So a little earlier, I purposely skipped over Robert Unger's question, which was, would you be able to give us some guidelines of what we should do in order to have indoor worship? Because I think that's what we've been talking about. But Robert, I wondered if we covered the areas you were thinking, or if you have other specific questions you'd like to bring in.
Yeah, thank you. I appreciate it. Thank you, Dr. Babinchak. I think I have enough to go on with basically what's been said over and over again. Protect those that are the most vulnerable, wash our hands, socially distance, ventilate as much as possible, and wear masks. Does that sum it up?
Those are the activities that I can say work to reduce the risks. Absolutely.
Perfect. That's it. I'm good. Thank you.
Thank you. Glad you could join us. Okay, one last interesting one that just popped up. Pastor Sabo, do you want to share a little bit about the news story that you were talking about?
Yeah, I'm just trying to compare what I'm hearing with the incident that happened out in Oregon last week in one of their churches where 74 people were infected. Now, I don't know what kind of precautions they were taking or not, but I'm just trying to, compare the two.
Yeah. And as I said in the beginning, I hope you were on. This isn't going to go away. These things are going to happen. We're going to have community settings where this is going to occur. It's going to occur in nursing homes as we move through. When a vulnerable population is exposed, these things are still going to occur. And the one aspect that is the concern for all physicians and infectious disease physicians especially is the point that we haven't touched on during this conversation, and that is the mutations, the mutants. As this virus evolves, how well will these vaccines protect us? And I can say as of May 11th, they protect us very well. But that may change by December 11th. Are we going to need boosters for these vaccines? My learned opinion is yes. We will need boosters of some sort. What those boosters are or what the frequency of those boosters are going to be, only time will tell in those situations. The short part of that, though, Pastor, is I don't try and compare the news stories where these things are occurring because we don't have enough information to draw good conclusions on in those situations. And so that kind of goes back to my patients and watching the numbers go, watching their heart monitor or their pulse ox. These things are going to happen. They're going to be bad things. They're going to be good things. But in totality, what it means for us as a society is a very different thing that way. And I try not to go too far out on those areas. My concern now is the things that are happening in India around these variants, how that's being disseminated, where our populations are still vulnerable, and what that could potentially do as we move over our summer months. We're going to see a continued decline in the transmission rates. And so I'm sorry, I apologize, I don't remember which of you it was, around the 5%, but we're going to start to see that baseline, and we've already achieved a lot of that baseline in a lot of the country. And that's going to be steady. The next is going to be as we get to the fall and the school year, and then the temperate areas, we start to move back indoors again, as to what is going to be the interplay between precautions, vaccine, and transmission. And that's where, come this August, September, I'd be more than glad to come back and speak with you all in that time frame as we start to move into the school year. And I offer myself to you in that regard. I'd be more than happy to.
Well, thank you, Doctor. We will definitely take you up on that. So are there any other questions that you wanted addressed and we didn't cover? Hearing none, Bishop Davenport, I wondered if you would like to say anything. Oh, I see you just said something in chat.
No, that's the only thing I wanted to do. I just wanted to say thank you. Thank you to all of those who joined the conversation, and a special word of thank you and gratitude to Dr. Babinchak. Just wonderful, wonderful that you broke it down in such simple terms that we might be able to understand and take back to councils and staffs and to the people that we love and care for, how we might do a better job of keeping each other safe. So God bless you. Thank you so much. And as Dr. Fisher, as you extended yourself, Doctor, and Pastor Fisher has already said, yes, we will have you back. So thank you.
And please don't hesitate. You don't have to wait for the 3 months. If there are pressing questions, please get them. I don't mean to volunteer you, Pastor Fisher, but these are very difficult times. They're difficult times. It's difficult to sort through a lot of the information, and I just want to make myself available to all of you as best as I can as a resource. I do have my own limits as well, but I do. This is important. These are the lives of our fellows here, and every life is an important life in this situation. And I think I took my oath many years ago and swore to protect life above all others and to first do no harm. And I live by that every day.
Thank you.
May I ask one question? Can we have a summary of what was said?
We will be posting the recording of this, and I think we'll see if we can get a summary put together.
I mean, it's attending church service with social distances and mask wearing, singing, not so much.
Right.
in brief.
And if you want to share some of this with others in your congregations, as I said, we will send out the link to the video so that you can share it. We do get a lot of talk about this every Thursday morning at 11. We have a office hours, which started out about communications and have become a lot about COVID and a lot about worship and a lot about technology. And so I will be happy to relay questions from there to you, Dr. Babinchak, if that's
absolutely. Please. This is the safer you make the community, we all make the community around us, the better it is for all of us.
Yes. And for those of you who are, dealing with the idea that we've done these great digital things now, in some cases we have audiences of people in other states. And so one of our challenges now is how to keep digital ministry working alongside of our in-person worship without totally burning out our pastors and deacons and musicians and other staff. So we'll be talking about that this Thursday at 11 with Pastor Keith Anderson. So you should have the links to that in the email, but I'll also include them in the follow-up email for this.
Okay, I will ask my pastor for the link. Thank you.
You are welcome. I think what we should do now is unmute and express our thanks to Dr. Babinchak for being so generous with his time.
Thank you.
Thank you.
Thank you all for what you do every day. As I said, this is a community. We all need to be in this together.
Amen.
Amen.
Thanks so much.
Thank you.
So
Thank you.
Everyone have a blessed rest of the day, and we will see you soon.
Amen. Thank you.
Thanks, Bob, for pulling us together.
Everyone.
Thank Bob. Thank you, Bob.
Thank you to Dr. Fisher. Yep. Thank you, Pastor.
Yep. Thank you,
Tim.
Pastor Fisher.
Bob.
Appreciate it. Yes. Thank you.